and welcome back to another edition of the Physiotutors Podcast. Today we have with us Natasha Wilch, a physiotherapist in Canada, an educator, and coming back to the focus of today's topic, someone who helps to mentor people with concussions on dealing with their day-to-day issues that they may face, and also obviously as a physiotherapist treating that, which ties nicely into one of the topics of today that we'll come to later, which is the Concussion Compass, that I'm sure Natasha will go into a little bit of further detail. And that's alongside our previous guest that we spoke to Concussions, Molly Parker, about. So, look, enough from me. Natasha, why don't you take it away and give us a little 1-2 minute intro, and then we'll jump on in.
Well, thanks so much for having me. So yeah, I'm Natasha. I live over in Vancouver Island in Canada. I own a clinic called Symphony Rehab, and we're a multidisciplinary clinic, predominantly concussion and neurological disorders, and particularly what I treat for sure. And then I'm all about entrepreneurship. So we have our online Concussion Compass business that we will talk about later, Telehealth and online educator. I love to speak and share my story and give education and inspire people around me. So yeah.
Perfect for a podcast then.
There we go.
Look, I mean, we've addressed it in the previous one, but for anyone who's not heard it, can you maybe describe for us what a concussion actually is, the pathophysiology behind what occurs?
Yeah. Do you know what's hilarious? Because sometimes for fun, I just like to Google things, because we know that Google is everyone's like go-to, right? If they don't know an answer, they go to Dr. Google. And for the fun of it, knowing that we were going to talk about this, I Googled just to see the definition of a concussion. And the first one that pops up which is wrong.
That's perfect for Google. Great
right?
Advertisement.
The first thing that comes up on Google search when you say definition of concussion is temporary unconsciousness caused by a blow to the head. The term is also loosely of the after effects such as confusion or temporary incapacity. This is why we don't trust Dr. Google for everything, because that is not the definition of a concussion.
No shit, I just Googled it while you were reading it out
right?
there as well. Yeah.
Yeah, so I'm just gonna kibosh this first, and then I'll talk about what is a concussion. So you do not need to lose consciousness to have a concussion. Okay. You do not need to hit your head to have a concussion. And so unfortunately, that is the old definition. And not one that we go by anymore. But it's terrifying to me that that's actually the first thing that comes up. That's horrible.
That's incredible.
What a concussion actually is a type of mild traumatic brain injury from a force either to the body anywhere or the head that causes a rapid acceleration, deceleration of the brain within the skull. That acceleration, deceleration can cause shearing or damage to the neurons and the axons within the brain, which will affect their ability to function and communicate. So this is where we look at, you will end up with kind of functional neurological kind of deficits or things like that in the beginning. So that's kind of your general definition. It leads to a metabolic and physiological changes within the brain that you cannot see on MRI or CAT scan.
If we can't see it on the MRI or the CAT scan, what's the best way for us as a physio to be able to define it? Now, one of the big eye openers for me in looking into the concussions was something that makes sense when you say it, but it doesn't necessarily have to be a blow to the head. It can be a blow to the body that would result in that jarring motion, or even someone falling over and falling flat on your butt, on your coccyx, can be enough to do it. So
the transition of the force up the spine, absolutely.
Yeah. So what should we as a clinician look out for there?
So there does need to be a mechanism, as in like there needs to be an event that happens for a concussion, right? So a lot of the time you'll see, so falls is one of the major indicators of concussion. If you go, sports obviously is a big one. Motor vehicle accidents is a big one. So all these things that will cause that force and that acceleration, deceleration. As clinicians, what we look at are some of those very common symptoms that come out of concussion, right? So there's different outcome measures that you can use, but we know concussion can affect cognition, it can affect emotion, it has physical changes and sleep. So as a clinician, when you are conscious, when you're aware of the mechanism that may have happened, so if you're watching a football game and you see a major hit and the guy whips his head back as he hits the ground, you're going to want to test for some of these common signs and symptoms that we know are associated with concussion. Same thing on the BMX track. We were talking about how my son's on the BMX track. If I see a major crash and I watch these kids go down at the speed that they go down on, they need to be getting screened for a concussion. And so we know that some of these symptoms, so there is definitely a physiological metabolic cascade that happens in the brain. And that cascade is what causes some of these neurological symptoms to show up. So that's where some of the balance, the vestibular, the eye movement things will come that we test for, the memory, all those things to look at, okay, did something potentially happen?
Okay. We're going to come to some of the subconcussive stuff in a moment, but you mentioned there, so your son on the BMX track. With kids as well, I think not a lot of people are aware, but in children, concussions can flip just like that. Is there anything or any kind of tips that you can give someone who may be on a sideline for kids sports or something to look out for? Because with children it can deteriorate quickly than with adults.
Yeah, and the thing is, it's funny because people think kids are more resilient, but pediatric concussions and the research take longer to recover than adult concussions as well, right? So an adult concussion, we say you are recovered within like 2 to 4 weeks-ish. Kids 4 to 6, so it's longer for kids in the research to recover, which is the opposite, I think, of what people normally think of. And I think sometimes, parents, coaches, trainers, whatever it is, because they think kids are so resilient. Oh, it's just a bonk. Oh, he just wiped off his bike. Oh, he just fell out of a tree. These are all things that we've all said, but they need to be aware that concussions can happen, and that cumulative nature of them, which we'll talk about, and how that can affect you. It needs, to me, it's kind of those things that need to be addressed. Like kids is research educating kids and parents, particularly on the effects of concussion, how they can affect it. I talk to parents like, oh, he fell and had a major crash and he just hasn't been the same ever since, or he needed glasses right after that, or he's never wanted to go back, or he just seems more anxious. But that for some reason, that link of taking it back to that concussive incident is missing.
Is there anything that would then link the severity of the initial concussion, the initial moment, to the symptoms or the signs that you may see with someone in the acute phase and then also long term further down the line?
Yeah, so I think people don't hesitate to say there's a concussion if there was a loss of consciousness, right? So if you lose consciousness, it is a more severe concussion. And people don't have a hard time linking those two together. I think the harder one people have linking are the concussions that happen. They may feel, the kid might not even say it, because the symptoms they might feel are a little bit headachy or a little bit nauseous or a little bit unsteady, but they might not recognize that in themselves, or they want to keep playing if it's sport. So they may not tell their parent. This is the one I see a lot, to be honest, in my young hockey players. They'll tell me what happens is a day or two later, when they go back to school with all that extra stimulation, now they have raging headaches. Now they feel really nauseous to the point where they can't hide it. And then they tell their mom and dad. So in those situations, those are sometimes harder to be like, well, you felt fine for 3 days, or you felt fine and you played and now you're not feeling as great. That seems to be the harder one to link for people. We forget that concussion symptoms don't all have to happen right away.
No, they can present later on. And I think, what about changes in, you mentioned there where a parent might say they had this fall and they've just never been the same since. What sort of changes might you see, not just with children, but also with adults, in someone's attitude or someone's behaviors?
Yeah, so the ones that I see most commonly is someone who may not have had a ton of anxiety, has higher anxiety, harder times paying attention, which then for kids commonly leads them getting diagnosed with ADHD, when potentially it could have come from that concussion. So, but when you think of adults and you think adults that have this, they say like, I can't pay attention. I see a butterfly and all of a sudden I need to look this direction, and I never used to be that way. So attention is a really big thing. And anxiety, depression is another really big one. Those are some of the biggies that come out of previous concussions.
Attention potentially being diagnosed with ADHD. Now, I'm skipping a ton of steps in the normal structure of how we go about this, but what would be the way to aid someone with that? Because if they're then being diagnosed with ADHD, depending on where you are in the world, they might just be given a butt ton of pills and said, oh, here you go, this is going to help you. Now, that's only further masking the issue. How are you going to go about helping someone with that?
I mean, for me, or at least in our study, I feel like we've become very reactive in nature, right? So we have an issue and then we go get help versus our preventative approach of, why don't I go see someone who does these things, that has an area of specialty, and see if they pick out something that I could work on to prevent something from happening, right? So you go to your doctor or most people go to their physician every 6 months or so for a physical, just because that's routine practice. But there's very few people that come to see me for an assessment to be like, oh, you know what? We can see that you're having trouble balancing, or we can see that your eyes aren't working, or we can see that you're not processing this vestibularly as well. Why don't we work on that now before you get a concussion or before something else happens? So with parents with ADHD, and there is more research starting to come out around, there's other things that you can do for treatment besides just medication, but it's, what else is there? Like, have they looked into nutritional stuff? Have they looked into potentially like training and brain training and all those sorts of things? What is the name of that thing? Totally blanking. There's a program out there that's, for ADHD, that's about brain retraining and getting those rhythms back. So there's things that can be done. The thing is it's not mainstream knowledge or nature. For my kids that come to see me for baseline testing, so I don't just baseline test them. I do the baseline technically within what's nature, but part of my baseline is a detailed ocular motor assessment, a detailed vestibular assessment. And if we see things come up that could be improved upon, I say to the parents, this is completely your choice. I know doesn't have any complaints about anything now, but here's some of the imbalances we're seeing. His brain's doing a fabulous job of compensating, but the effects of your concussion are also going to depend on your starting point. So if you're starting with a brain, I always say, are you compensated or recovered? So if you're starting with a brain that's already got a visual system that's stepping up to the plate for a somatosensory system or vice versa, and then you get a concussion, there's no guarantee, but it's possible you may have a harder time than if you had started in a more balanced place. And so what I do for my concussion clients or for my kids or anyone is I baseline, I say, here's what this looks like. Here's what we could work on if you would like to. And then I monitor them throughout the season. So I use an app that's FDA approved that it's basically got like kind of the SCAT, but gamified. So I get to watch their balance, their eye function, their cognition, all that stuff throughout the season. They do a check-in once a week and I get all the data live. So I can watch it and see how they're doing. And we know, like we've read those studies, that 5 out of 10 concussions go unrecognized. So all of a sudden, if I see this data and I start seeing this kid trending downwards, I call the parents and say, hey, I just want to check in. How's Johnny doing? I'm noticing his scores are not doing so hot. Is it that he's in testing? Is he stressed? Has he had some falls? Like, what's going on? Do we want to bring him in for a checkup? Or do you can you get him to do another test tomorrow so I can see what happens? So I'm trying to catch those nuances before it becomes a big thing.
That whole concussion prevention is, an area of the field that I was totally unaware of. How do you find, we're definitely drifting off topic here, but how do you find are people receptive to that, or how receptive are people to that? Because especially sometimes with kids sports, parents can be extremely invested and not necessarily maybe want to take the advice that's given by us as healthcare professionals, or the coach that might say, hey, maybe we take the break. Sometimes parents can be the pushy one, sometimes the kids can be the pushy one. There's always that. How do you find, how receptive are people with that?
It's mixed. And it's mixed because there really is no hard evidence that says, here's how you can prevent a concussion. right? The research that looks into that, it looks at, if we increase neck strength, does that help? If we do vision stuff, does it help? If we give you a better helmet, does it help? So there is no hard, fast, like level A evidence that says, if you do this, you will do better. And so that's kind of a hard piece of it. It's like, it's going off my clinical judgment and clinical experience more than anything. Parents are much more receptive if they have another child that has already had a concussion and had to go through the rehab process, or if their child has already had one concussion and now they see that they would like to have that fit. So I will be honest, it's definitely a harder, parents like the idea of it, but it requires paying for services. And when you're not sick or you don't have an issue, I think that's just where our society doesn't always go.
Yeah, it's one of the discussions that I've had a lot recently with a few friends of mine, that people are more than willing to go spend $100 on a personal trainer session to go to the gym and lift some weights, but €30 or I don't know how much it is in Canada, but however much it is for your physio session, people are then a little bit more like, oh, I don't know if I'm gonna.
Well, I think what it comes into with the brain stuff too is you can't see it, right? So you sprain your ankle, or you can see your ankle, you can see when it's swollen, you can see when it hurts, or you can't see when it hurts, but you know what I mean. And so you get that, you can see that it's hard to balance or becomes more stable. So you go through these things, you understand that you have to train this. As an athlete, you want to train agility, you want to train speed, you can see the physical result. You can't see your brain. And so the measures we do and the outcome measures we take when we assess it are, they're being seen through another system. They're being seen through the motor system or whatever too, right? So I think sometimes it's hard for people to wrap around. And our side, it's like, how is this my brain? Like, what are we working on with my brain? And so my thing is, I would love to, and I've always wanted to do like a preseason camp where it's just like, you tack my portion on and we can say like, let's do your brain assessment. Like, let's get this. And then let's give the trainers some specificity for you. That's like, no, you need to work right this a little bit more because of these findings, and make it that more specific. But, onto the list.
Fair. Yeah. It's something to come yet. Talk me a little bit through the concussion prevention stuff, because obviously, like, if we're talking about the FIFA 11 plus for soccer, for football players, there's evidence there. It's quite easy to find and show it and see that, hey, if they do this stuff, you can reduce the amount of injuries they have. Now, obviously with concussions, like you say, there's so much nuance around it. It's so difficult to pinpoint certain moments and whatnot. Talk us through a little bit of what you do with the concussion prevention. What are your metrics that you're using there? I know you've mentioned a few things with the balance and the coordination and stuff, but yeah, what?
Yeah. So, like I said, this is an area where there is definitely no hard and fast rules out there. There's been studies that have looked at whether you do visual training, does that help decrease concussion? And the theory behind that is potentially you're picking up more of your peripheral vision, your reaction time's faster, so you see things sooner to be able to move your body out of the way. So there's been a few studies that have found that that's been helpful. There's studies that have looked at if you increase neck strength, will that help prevent a concussion? Because we know that concussion is that acceleration, deceleration injury. So if we can improve the neck strength, will that help? But there is no like, this is what you do to prevent a concussion. Like, that just hasn't been published that I've read anyways. And so for me, I kind of take it, it's for the clinical approach, it's, we know a concussion can affect your visual system. We know it affects your vestibular system, your autonomic nervous system, it can affect your somatosensory, and how all those things communicate together. Like, that's what it does. It doesn't just affect one thing. It can be widespread. And so in anything else we do in life, how something affects you, how you start, like your initial starting position is going to, like how that is going to affect your response to a situation. So for me, it's if I look at all these things that a concussion can affect, and I have kind of those measures of what those are, like when I do an assessment, and I see things that aren't ideal or that we could improve, clinically, to me, it makes sense to improve the starting position so that if an incident should happen, it's going to be more resilient. And when we talk about Like you'll see research that talks about, if you recover from one concussion, you're not at higher risk for a second concussion. You'll see research that says the exact opposite of that. And then you'll see research that says concussions are cumulative. And so depending on who you speak to, some of the thought processes are, well, if you think about it, if you get a concussion, that affects that starting system, right? So it's going to be, and if you don't do anything to treat it, and it instead of recovers, meaning that system doesn't step back up to where it was, but another system gets unmasked and steps up and takes off the role of the system that's become dysfunctional, you've compensated. So you're in a less resilient starting point than you previously were. So then if you get a second concussion, well, you're already starting at a less resilient place. So it could potentially affect you more. And so what happens is when I get people in the clinic that have had 4 or 5 concussions, and concussion number 5 is the one that's knocked them into post-concussion syndrome. So they're 6, 7 months, 2 years, whatever it is out. And they give me their history and they'll say, I've had 5 concussions. And the response is usually, I've recovered fine every time. The first thing I ask them is, did you get rehab for any of those ones? And the common answer is no. So it's like there's potential that, yeah, they may have recovered in there, or their brain may have compensated, and then finally it was the straw that broke the camel's back that kind of led them in. So in terms of, I'd use, for the kids that come in when I track stuff, I use a system called EQ brain performance. And so it is like, they've been FDA approved in the States for all their balance measures and stuff, which is really great. It's a Canadian company, which is, I love it.
Represented.
But it gives me this trend for these kids. And what's really cool is I had this client once who she came to see me. She traveled up to see me. And so we did it at the beginning, and then we did her treatment for the time she was with me, and we saw things improve. And she went home with a home program and kept improving. But then all of a sudden, there would literally be, she'd be like, okay. And then she would tank. And then she would come back up. And then she would tank. It was literally every 2 weeks. And I was like, what the heck? And so I called her and I said, what is going on? Because it was literally like clockwork every time she had some sort of an appointment. It was too much for her nervous system, I guess, is my hypothesis. And all her scores would plummet. And then she'd work herself back up over the week. Because it wasn't enough to do any actual damage. And then she'd kind of stay there, and then she'd go, and then she'd plummet. So it was like it wasn't doing, whatever the treatment she was doing, it wasn't doing much to help from a neurological assessment standpoint.
Jeez.
It was really crazy because it was literally like clockwork. And so being able to have this data is really cool, because then the other thing when you start to see that stuff is we always hear that like stress is a factor and all these things will affect your performance on these things, which is why this company goes against the one-time baseline, right? At the end of all the tests, there's like a wellness check-in. So there's like a symptom score and how are you feeling today, And so it just gives you more context to the person's life to be able to have an understanding of where they're at.
And like you say, having that data can be so useful in seeing those patterns. Is just when I have patients coming in and whatever the issue was getting better, and then something happens, they're not able to really put their finger on it, they're not sure when it was, but it then dropped off. Okay, cool, let's treat again, we'll go through the exercises, make sure getting better, all of a sudden it drops off. You can't figure it out, you can't put your finger on it. So having that tracking there, especially with something like dealing with the brain, where it's not like a knee where you can see the swelling and it's very easy to see if it's reacted, if it's a meniscus issue or something. There's something deeper going on there. But pulling that back to what you were saying about concussions, some people say that they're not cumulative, some people say they are, yada, yada, yada. What do sub-concussive forces, or how can they play a role in this? Because something like heading a ball or whatever, no one will think that can be quite bad, or quite bad. No one will think that's sinister, but yeah.
Well, and you think of football and hockey and all our contact sports, right, where there's constant hitting, but it's not giving you a concussion. And so this is another big area of research right now as well. There's a lot of research going into either repetitive head impacts, so not concussion, but repetitive head impacts, and is there neurological consequence later in life? There's lots of research going into repetitive concussions, and does this increase risk of neurological issues later in life as well? So Parkinson's is a big one they're trying to do some research about too. And so the answer is undecided. But I did actually, and I took notes on this because I wanted to be able to actually quote it to you. So there was a study that actually came out this year in neurology that looked at that. It looked at repetitive head impacts, and then it looked at TBI and TBI loss of consciousness. Okay, so kind of those three different, if you look at like severity levels, if you're looking at it. And what they found, so across the board, the TBI with LOC had the greatest issue like later in life with cognition, memory, reaction time, and processing. But they did find that there was a group within this repetitive head impact group. And this study was done with 13,323 people. So it wasn't a small N.
Not a small group. Yeah.
It was a big group. It was done through a brain health registry in, I want to say Boston. I could be wrong on that, but one of those big groups in the US. And they said when repetitive head impacts had the strongest effect on later life symptoms of depression, but TBI, LOC plus repetitive head impacts had the greatest symptoms overall. So it's one of those things that I'm going to quote him because I don't want to plagiarize his words. It should be noted that not all people with a history of repetitive head injury will develop later life problems. And so I think we need to know that, because you think of the fears around CTE and everything right now, right? So
that's exactly where my head was going. Yeah.
So, and we can touch on that a little bit too if you want, but not everyone who has repetitive head injury will develop later life problems. But they have found that could quite possibly be an important role with repetitive head injuries with later life development of cognitive and emotional problems. And cognitive specifically, they looked at reaction time, processing, and memory.
Okay.
So, yeah, it's definitely, it's an area of interest right now for sure. It's an area that they're looking into. Again, it's one of those, there's no definitive statement. This study just came out in January, June or January of this year. So it's brand new, saying that, yes, this is definitely there's definitely that correlation. But it doesn't mean that everyone has to worry and stress and fret about that.
Okay. But seeing as we're already there and we just touched onto it, CTE, now that's something that, to the best of my knowledge, is something that can only be diagnosed posthumously, correct?
You are correct.
Yeah.
So,
but then that has impacts massively with people. It can manifest with depression, changes in behavior, right? Then you've got other neurological symptoms may develop as well. Can you maybe talk us through some of that and touch on that briefly?
So there's two major groups in the United States researching CTE right now. So there's the McKee group, and then, I always say his name wrong, the gentleman that was in Concussions, the Will Smith movie, I always say his name wrong. That gentleman, that group. So there's these two major groups. And what has been fascinating though is that they found, so when they look at CTE, they're looking at these plaques within and these neurofibrillary tangles within the brain, right? Mm-hmm. And what they've actually found is that they're finding these tangles. So these tangles show up in phases or stages, depending on which group you're talking to, and then as you go later in life, they have a greater amount. They're also looking at the difference between Alzheimer's, because Alzheimer's also has this tau and some of these tangles. And the difference that so far, from what I remember, is the Alzheimer's group, the location is different versus CTE. But what was fascinating with CTE that came out is you don't necessarily have to have, in some of these autopsies they've done, a major head trauma or concussion history to have the proteins. Okay. So where we've been thinking, where people's terrified about, I have this concussion history, and yes, it's absolutely there. And I don't know the risk of one, but the studies are also showing that you don't have to have a concussive history to have this tau and these neurofibrillary tangles that accompany CTE, which is really fascinating, because then it's like, okay, well, what else is causing it? Right? If it's not the head trauma over and over again, what else is contributing to this to these other people? But it's the things you've talked about. So it's the depression, the behavioral changes. As it gets later in stages, it can affect the cerebellum and the temporal lobe, and the temporal lobe is like sequencing and memory phases and all these other things. So it can have a widespread effect throughout the brain, but it definitely comes in stages. It doesn't all happen at one time.
Oh, yeah. Okay. And then, is there any way in which people have begun to be able to recognize someone who is at risk, especially if you say that it's not, they're now coming onto research showing that it's not necessarily someone who's had repeated brain injury, that may have the CTE or maybe developing CTE? Is there any way that these people can potentially be identified, or any links between?
I think that's why there's so much. I think that's why they're looking closely at Alzheimer's and dementia, because it's usually some of that memory stuff is some of the symptoms that come up. So right now, no, we know that these are the things that happen, and we treat them as we see them. But to know if that person's going to have CTE, we're not going to know that until.
It's anybody's guess. Yeah. Okay. Pulling it back to the concussions, you've mentioned that you use EQ brain performance stuff. Are there any other test batteries or questionnaires that you use, even if we step away from the kid stuff that you do as well with adults? Is there anything specific that you use there?
Yeah, so I use a right eye system, which is a ocular motor tracking system. So it's got infrared cameras in the base of kind of the computer that will track the pupil. So that lets me look at my ocular motor in much more detail. So my smooth pursuits, my saccades, are they accurate to target? Are they actually following a target appropriately? I will use infrared goggles to look at, do they know where they are in space? Do we have eye movements in the dark that shouldn't be there? I don't have a VNG yet, but that's the next one on my list.
VNG?
The video histogram. I can't speak today. Basically.
You haven't hit your head, have you? Do I need to be worried?
Literally, it's 11:30 for you, and it's like 3 o'clock in the afternoon. I should have words. I can never say the words. So VNG is a system that basically it puts your eyes in the dark again and lets you do video recordings of your eyes. So it lets me look at smooth pursuit again. It lets me look at saccades. It lets me look at the optokinetic reflex, gaze holding, all these different things. And then it records it. And then it gives me graphical reports that I can look at as well. I use those two. I use a bit of a posturography system to look at center of mass and sway. And then so those are the diagnostic-y things that I look at. Outcome measure wise, when my clients come into the clinic, because we know that concussion is, these multi-domains, we have these different phenotypes of concussion, they do a basic Rivermead post-concussion scale. They do what's called the BIVIS, which is more of an in-depth vision kind of questionnaire. And they do a GAD, so a general anxiety and depression. So my multidisciplinary team is made up of physios, OTs, speech, clinical counseling, and I feel like I'm forgetting someone. So if they come in and that GAD score is maxed out and they start to tell me about things and anxiety symptoms are off the roof, I'm going to pull in my clinical counselor pretty early to help us support them. We also work really closely with a couple neuro-optometrists in town. So if their vision stuff is off the charts and we need to pull in a neuro-optometrist, we'll pull in a neuro-optometrist as well. So they get those 3. And then there's other ones that I'll use based on where we are. So if it's sideline stuff or early stuff, there's the VOMs or the SCAT as a sideline tool. Those are the neurobehavioral symptom inventory is another one I quite like for just having a general concussion inventory. But those are the main ones that I would pull out. I have a whole slew of them, and then if you're looking at dual task of gait always.
Now, you mentioned there that you're working in that MDT, and it's something that I think I've thrown later down in the questions, but seeing as we're there now, was that something that you started using initially, or is that something that you developed over time? Did you see that there was really a need for you to be working in tandem with somebody else on different aspects, different areas? Tell me a little bit about that, because from personal experience, I think it's massively underrated and understated how important that can be.
Yeah. So when I started Symphony, I opened in 2015. We opened our first brick and mortar in 2016. So when I opened the clinic, it was already neurologically focused. And I had worked in the hospital system on a neuro floor. And I worked intricately with OTs and speech pathologists and rehab assistants to help plan for our client to get them home. That was mostly strokes and severe brain injuries, to be honest. But that interdisciplinary nature, that multidisciplinary team of having everyone's brains together, because everyone's got different strengths. And then when I started working with concussion clients and realizing what was happening is usually they've seen several other practitioners by the time they found me, and they're getting one practitioner that's telling them one thing, another one that's telling them the next. They're so flustered that they just didn't even know where to begin or who to begin with, that it just kind of reiterated that need to have at least some of the major components that can be disciplined under the same place. They only have to repeat their major history once. The team, they give consent for that main thing to be shared. So what happens is someone comes into the clinic, especially if they come in with a concussion, they're usually started with a PT. And we ask all these questions and do all this assessment stuff to determine, there's been times where it's like someone is so anxious or has such issues that to start with me would be futile. So they start with the clinical counselor for a few sessions and then we link up. We had a client once, it was amazing, with my clinical counselor. So she does EMDR, so eye movement desensitization therapy for reprocessing trauma, except that most of our concussion clients, you can't use their eyes. Because they're symptomatic, right? So the second you get into the shoe, they just feel like they're gonna vomit. She uses other sensation. So what's been really cool with her is part of my assessment is assessing that somatosensory and all those things. So I assess, do they know where they are with the auditory and space? I assess joint position, I assess touch. And if I find that one of those systems is doing better than another, then I'll tell my clinical counselor that, and she'll use that system for her EMDR therapy.
Okay.
So we just and again, there's no research to support that. That's just something kind of we've identified and played with together, that if she's having a hard time finding a way in, and I find that this works really well for them, we share that information and we both have better success.
Yeah, it's the benefit of the multidisciplinary team being in-house for you guys to be able to do that.
Yeah. Well, and for our PCSs too, they're just like, I just have to come to one place. They're like, I don't have to remember. I just need to, they're like, I don't even need to remember who my appointment's with. I just need to show up and you'll tell me who I'm seeing.
Yeah, I'll rock up, point me to which door, we're done.
Some of them are seeing physio and clinical counseling and speech. And so literally all they put in their calendar is Symphony, 2:00. And they just
Oh, handy. Jeez. Okay. And then, so do you, in every intake then, it's not just your physio intake, you're then also screening for someone else as well? Or do you guys do intakes together?
We don't do intakes together because we're a private practice clinic. So if we did intakes together, we would have to bill for both our time. And so trying to keep it cost effective for the client, we do the intake and we kind of screen for these others. So that's why we do some of those outcome measures right on intake. So we'll screen for other things in our intake to then refer out or bring in. Yeah.
Okay. And what are the key points, would you say then, within your intake that may flag for intervention with somebody else alongside the physiotherapy?
Mm-hmm. So I would say definitely the most common one is our clinical counselor. And that's that GAD, so the General Anxiety Depression GAD-7 scale. If people come in and that is like maxed, you can only score it out of 3, like on each thing. If they come in with 3s down the board, that's an issue. then I'm just kind of already like peaked of like, okay. And then paying attention to how they're talking about things in the session. I will ask them about anxiety too. I'll say, how are you doing with driving, or how are you doing with things? And if it was, especially if it was an MBA and they're like, I can't go past that spot on the road, or I can't get behind the wheel of the car, it's like, okay, like you need to pull someone else in. I'm having nightmares, all those things that can signify PT. I mean, we're not allowed to diagnose anxiety, depression, or PTSD, but we can pick up on those things, that if those things start to come up in conversation, I'm immediately referring out, and bringing the client and saying to the client, like, here's what I can help with. And so what I do too is I go through my whole assessment, and then I sit with the client and say, okay, like, here's what I'm finding. Like, this is the part that I can help with, but this part over here that you shared with me, I really think it's important to get this addressed, and here's why. Here's who we have on our team if you would like to work with her. And then I would say, if this doesn't jive, we'll find you someone else. So I think that's the other thing too, is most people work with amongst our team, but if for some reason the personalities don't jive together, we'll find them someone else in the community. But yeah.
Okay. And then coming back to the concussions more specifically, you mentioned earlier about the different places that someone can be. They can be in where their brain is in the recovered phase, or they could be in that compensated phase. Now, the compensated phase may not always, but it may be that they haven't sought any help or rehabilitation for their issue now, or been diagnosed with a concussion. Like you say, sometimes they can be misdiagnosed. Now, what are some of those dangers that may be there for an individual if they are either misdiagnosed or undiagnosed with a concussion, and they just power through?
I think for some of those people who don't, especially the ones that don't get diagnosed or get misdiagnosed, and they're powering through and they have symptoms, it can lead to unnecessary medications. It can lead to unnecessary surgeries. So the amount of people that I didn't realize that have surgery on their necks that they probably don't need. I didn't even realize it, but I guess there's surgeries you do for like occipital neuralgia and stuff for neck pains and issues. I don't know. But it's basically, if it's getting missed, the client goes through a whirlwind of medical investigations and trials, and that they may not have needed to do. Right? It might have been, you think of dysautonomia is one of the biggest ones. So that I see in concussion clients, that sends them through the gambit of health professionals because no one can understand what the heck is going on, right? So dysautonomia is that imbalance between your parasympathetic and sympathetic nervous system, which can have effects on your digestive system. It can have effects on your blood pressure. It can have effects on, like, it's system-wide. And so what happens is, and I think of one client in particular, she's seen cardiology, she's seen GI docs, she's been on bowel protocols, she's been on all these different things that literally for this client has led to like one medication after the other being prescribed, because no one picked up on her concussion, which started to lead to this stuff that happened years ago. And so for this client in particular, it was like, she's got dysautonomia. She most definitely has to have some metabolic issues going on with the amount of medications and stuff she's on. And I have nothing against medication. It definitely serves its place for sure. I think what people need to realize is medication doesn't always treat the issue, right? It treats the symptom. So if you can identify what is causing that symptom, then maybe you can decrease the dosage or whatever it is, right? But connecting this client with a functional medicine or naturopathic practitioner, this person has been unable to have a bowel movement in ages, but within 3 weeks on a protocol to reestablish kind of that metabolic base, she's not having any issues anymore. But this was something that was missed, and she was just, because it was literally system-wide, no one could figure out what was going on. She'd had x-rays, MRIs, CT scans, everything, and everything anatomically and pathologically was coming back normal. And so this is kind of and I think she's an extreme case. Like she's not the average person at all. But I think what happens is it's just, and you never know if you've compensated or recovered unless you get tested and you go through an examination, because you can feel 100% fine if one system is not working as strongly as the other, because your brain's in good health and it's compensating. So
yeah, the body is a fantastic machine that will compensate for you without you never even realizing that there's something going on. Now, with that, there's a few different systems within the body that you identified with the dysautonomia. Now, it's probably a bit of a difficult question, how long is a piece of string, but what sort of things could we look out for with the dysautonomia if we have someone who we suspect may have suffered a concussion that is having multiple different issues? Where can we at least begin to lead the way, or not necessarily lead the way, but guide the patient towards getting that looked at?
Physio can do a lot for dysautonomia, a lot. So the first thing is identifying it, right? And I think that's where a lot of it gets missed. So dysautonomia, people tend to group dysautonomia and POTS together. POTS is postural orthostatic tachycardic syndrome. So POTS is a type of dysautonomia. Dysautonomia isn't always POTS. But looking at things like postural changes in blood pressure, looking at things like, are they constipated or not? We know that parasympathetic lets bowel movements happen. Sympathetic system does not. The big thing is looking at using pupillometry to look at things like pupil size, speed of pupil constriction, is hippus present? All of those factors around pupillometry there's tons of research coming out about that and how pupillometry relates to the function and the status of your autonomic nervous system, and how you can use that to assess. As a physio, most physios look at exercise testing to kind of look at that piece. The problem is if you have a client that can't even stand up because they're so dang dizzy, you can't do a Buffalo treadmill test, right? You could look at a test called, it's an isometric grip, like hand dynamometer test. If a normal person, as you hold this test for the duration of the time, should have a nice steady incline in blood pressure. Someone with dysautonomia doesn't. Their blood pressure doesn't change. So there's these indications that you can do, or these tests that you can do that very easily in a physio clinic to help give you the old gold standard is the tilt table test as well, to see whether this person's autonomic nervous system, which is what dysautonomia is operating or kicking in when it should and appropriately. And then from there, it's understanding, okay, so you're like, okay, this person has dysautonomia. They have a postural component too. Sometimes where I think happens is the therapists aren't necessarily doing the wrong therapies, but they're doing them in a postural position that the patient can't tolerate. So they're working with them in sitting or in standing, which spikes their heart rate and makes them super tachycardic, when if they had started supine, given them a compression for their legs to work on, and then slowly started to work them up, you're challenging the client where their nervous system can actually function and strengthen, as opposed to putting them in a too challenging position right away. But as physiotherapists, we can do a lot with dysautonomia.
Okay. Now, how do you then go about educating your patients that, hey, this is what's going on, this is where we need to go forward with that? How do you approach that with people?
Yeah, so when a new patient, so I see a ton of post-concussion syndrome in my clinic, and then acute as well, but significant post-concussion. So literally when someone comes in, they go through a 2-hour assessment. And I say to them, we're going to do the full assessment, and then I'm going to sit down and go through everything with you and explain what is happening, if I can explain it. And I'll say to them, if things are showing up that don't make sense to me, or I don't feel like I'm the person to help you, I'm going to tell you that, and we're going to find you someone who can. We know, I think as therapists, how our autonomic nervous system is supposed to function. If it worked, wonderful. We know what our vestibular results should be with things like our head thrust test and dynamic visual acuity, right? We know what our ocular motor function should be. We know what a normal latency on pupil constriction and 75% recovery should be. So when I do my assessment, I assess all of the domains. I assess how they process sensory information coming in. I do the pupillometry. I do all of those things. And then I look at it together as one. So sometimes what happens is someone is actually they have a huge deficit in one area that we need to address. Usually there's deficits in little areas. There might be more bias to one. And so then I explain what that system does and how we can correct it, and then what that should look like for the rest of them. I think one of the most interesting, he was a great kid. So he was a hockey player that got referred for his concussion had been a year out, but since he was one of these ones that since that concussion was dealing with persistent anxiety, like every time he'd go to step on the ice, anxiety was was ramped up. And obviously if someone had said, I'm referring to you for anxiety, I'd be like, well, I'm probably not the person you want to see. But they were like, I had a concussion. And I was like, okay. So in doing his assessment and looking at how his eyes function, for example, I was like, every time you shoot the puck, I'm like, are you missing the net? Like, are you shooting high with the net? He didn't tell me that, but he looked at me and he was just like, yeah, every single time. I'm like, when you're on the ice, if you're on the left, are you missing people on the right? And he was like, yeah. And the fact that I could explain the challenges he was having in the game based on his assessment findings gave him that trust in me to then say, okay, here's what I'm seeing. And so his anxiety was very much based in what was happening neurologically within his brain, that when we fixed that, his anxiety went away. I would never say I treat anxiety ever, but I treat the underlying issues, which in his case, for him, I said to him, he loved hockey. It was his life, and he wasn't playing as well anymore, which then led to that anxiety. So when we could get his game back up to fix the issues that were leading to the challenges of the game, his anxiety dissipated. So being able to do this big assessment to the clients and then explain to them, here's what this is, here's how this relates to your symptoms, and here's what we want to do to correct it. Acute concussion is different. Acute concussion has a huge education base right off the front because they need to not push right away. So acute concussion, I take the history, I do the assessment. There's a big education component with my acute concussions off the hop because I want them to recover properly in that acute phase, not push too fast too soon. That gradual reintroduction is so key because I don't want them to be prolonged if we can mitigate it as much as possible. But yeah, it's all about, being transparent. I think clients, if you don't know something, say it. But offering to help, that's what they need to hear and want to hear.
What about addressing with people that the moment they feel good isn't necessarily the moment that things are over? Because that's a tough one, regardless of whether it's concussions or if it's an MSK injury or what have you. That's always difficult to broach with people, or people don't want to pay any mind to it.
And that's the biggie too. It's so especially that acute concussion phase, we try to, just because your symptoms are gone doesn't mean you're recovered. And that falls into kind of that metabolic cascade we talked at the beginning, right? This physiological process that happens, research is showing can take anywhere from 4 to 6 weeks to recover, 2 to 4 weeks, anyways, to finish, right? But that doesn't mean you necessarily have symptoms for 6 weeks. And so you have this, I've heard it referred to in so many different ways. When it was first taught to me, it's like you have this window of vulnerability where your symptoms are pretty much gone. You feel pretty good, but this would be that time frame when your brain's not actually recovered yet. That if you get a second concussion in that time frame, it's going to be a longer recovery after. So the best way for me, this is where baselines are helpful, because my baseline test, like I said, it is that initial, but then I also have some of those other performance factors that I like to do that involve hand-eye coordination and all these things. And one of the best examples I had, which kind of reiterated to me why I do like baselines, is I had another young hockey player that I worked with a lot of hockey players on Vancouver Island. He had come to see me and we rehabbed him from one concussion. He was feeling fantastic. I kept him off the ice longer than he probably wanted me to. But before he went back to play, or when he was cleared to play and good to go, I put him through a final round. I have a system called Synaptic, and it's kind of a sport performance training tool. So I put him through some of the assessment pieces on Synaptic so that I could have it. And then something happened. He got another concussion. And it was a brutal concussion. I saw him 2 days after and I was like, oh gosh. And he went home because he didn't live on the island. And then he came back saying he was ready to play, but his parents wanted him to come see me first. And I did my assessment and I was like, you're not ready. And he's like, I'm fine. Like, I'm asymptomatic. I'm running. I was like, you're not ready to play. Like, he had some vestibular findings and he had some other things. And I could not, like, he was asking, and I get it. This kid loves it. I popped him on my synaptic system where I had his baseline when he went back last time. And that was the wake up call, because he scored 40% below, even though he tried so hard to do this test than his normal. And it literally took that for me to saying, you're not ready to go back. And then we worked with him for another 2 weeks, popped him back on again, and his scores were all good. And then I cleared him to play. So that's where, like, for that person, like, he was a hard one because he had no symptoms. Symptoms are subjective too, right? So that's the tricky part, is if someone says they feel dizzy, you can't argue that. If someone says they feel pain, can't argue that. So he told me he was symptom free. You take his word, I take my client's word for it. But other things were telling me that he could not go back. And so I think that's why anytime you're, like with anything, you're working with someone, you can't just use subjective symptoms as your reason to discharge, as your reason to clear someone to play, as your reason for, moving forward.
Okay. And then what do you do with someone like that treatment wise?
Yeah, so he's on his assessment, if I'm not mushing him together with someone else in my head. He had residual vestibular issues, hand-eye coordination issues, accuracy issues on particularly one side of his body. So we worked on those. So for him, oh gosh, that can be anything. So that can be my synaptic for hand-eye coordination. That can be vestibular exercises, whether it's gaze stability or reaction time exercises. That can be a Marston ball if I'm working on depth. It can be any number of different things. Those are a few of the things that I do. And then we just kept challenging those systems and then integrating the systems together. So then, okay, we've worked your vestibular system, your gaze stability looks really great. Is your gaze stability fantastic in different environments? Can you respond as quickly on a stable or unstable surface? Can you turn as quickly to the left as to the right? Can you move your neck when you're standing and sitting in the same range of motion? So it's taking and training that system, but then making sure that system integrates with other things. And so you can be a dynamic human being. You don't have to always be in one position to get optimal function.
What about with someone who's displaying some of these dysautonomia symptoms? What are you then doing treatment-wise?
So it's always if that is present, it always gets my attention, always. And so it looks at two things. I'm looking at, is it actually POTS? So are they getting that blood pressure tachycardic piece of things, which then means in my treatment, there has to be a postural component to that treatment. So there has to be that supine or 3/4, like partially reclined position. So if POTS is present, you need to pull in postural positions significantly when you're treating. But I put them through the same assessment. And I'm looking to see, are there systems that are optimally working or not optimally working, and are they communicating properly with others? Am I getting the outcomes I should? Your vestibular system drives really big into a nucleus that drives your parasympathetic nervous system. Your trigeminal nerve feeds into that part of your brain stem, like your trigeminal nuclei, that drives that autonomic nervous system. Your vagus nerve, it's how do you stimulate your vagus nerve? So usually dysautonomia is excessive sympathetic system drive. How can we stimulate that vagus nerve to bring on your parasympathetic system? Something simple like humming, gargling water, if you have the gag reflex still. That will stimulate your vagus nerve. Some of the acupuncture points, if you do acupuncture Shane Manin point 0, are parasympathetic points. There's different places that if you can pull in and stimulate this nerve while you're doing some of your other treatments or as a treatment in itself, you'll activate that parasympathetic nervous system a bit and then try to work to balance it out.
Look, we're about an hour in now, right? And there's so much that we've covered, so much that we've spoken about. And that's also so much that you're doing in clinic. And that's so far we've been pretty much active in treatment wise and stuff. And you've mentioned, and we've spoken about, these guys have difficulties outside of it. They have difficulties in their day-to-day life, also keeping track of things. Now, this is where something like Concussion Compass can come into it. Can you maybe talk to us a little bit about that and what it is and how you utilize that in treatment for these patients?
Concussion Compass was created by myself and Molly Parker. So as you said, she was a previous guest. So Molly is a physical therapist who is on her own post-concussion kind of journey and has been for several years. And then obviously I'm a clinician who treats it. So we have this really unique partnership between us of someone who's truly lived it and living it and someone who's dedicated her career to kind of treating it. And Compass came up for two reasons. For me is because I was seeing clients in the clinic all the time who literally didn't have anyone around them who got what they were going through, and they felt like they were constantly have to explain things, and it was just emotionally draining and incredibly frustrating. They had questions about, nutrition and tips and tricks and all these things that could literally take up entire treatment sessions to help them manage this day-to-day kind of life. Like, how do you grocery shop? How do you get up in bed? How do you go on social situations? All these things that are still a huge component of life, to navigate those while you're in treatment. Online and like through Instagram, I'd get people messaging me saying, I'm really dizzy, who do I go see? Or I've seen this person and I don't know what to do. And it just got, there's all these, there's this other stuff. And Molly would get this on her end too. And so together we created Compass. And so the point of Compass is there's really three pieces. There's a research done for you mini courses section, which is literally the information people Google so that they don't get that terrible definition of concussion. Right?
Right.
So that's where Molly and I, we've created that information for you. So there's a section on dizziness, there's a section on headaches, there's a section on nutrition. So you don't have to spend hours going through screens, which we know people don't tolerate really well. We've done that research for you and we've put it there for you. So that's kind of one piece of it. The part that we love, like the other two, we love the whole program, but mentorship and resources. So we want to be able to help people. We don't want to, we know we can't cure them through Compass. It is meant to be a complement to rehab for people, but we can help guide them. And so we do live coaching calls. So we'll do a mentorship call a month where we'll teach on a topic. So this month, for example, it's summer. People are starting to have barbecues again. It was called Navigating Your Social Summer, where we talked about how do you have a social life? Like, what are the tips, the strategies? What do you say to your host so that they don't get upset when you have to leave? Like, that's the stuff we talked about. We do office hours where literally I sit there in a Zoom room and I just answer questions. And Molly, so I do that for an hour a month, and Molly does that for an hour a month as well. And then we also invite a guest expert on every month, because we are not experts in everything in concussion at all. We don't try to be. We're very clear when we say that's outside of our scope of practice or we don't know. So we invite people on who are. So we've had Dr. Chapik to talk about kind of nutrition. We are having someone to come talk about hormones. We'll have a neurooptometrist come talk more about vision, because that's not our area. And we want them to have access to these professionals. There's a zillion resources in there. But then the community is unbelievable. So we have a private community that goes with it as well. And so we use Facebook for it, but someone can post a comment or a question, and not only will Molly or myself answer it, but so will 40 other people who have gone through that and sharing their experience and their tips. So Concussion Compass is, what we do, as a clinician, it's amazing, because I know that if I guide my client to it, they're going to have support. They're going to have valid and awesome information from clinicians who care. It doesn't take the place of one-on-one rehab. So as a clinician, I know they're getting this great info. As a client, as the same thing, we will help guide them. If they don't have a clinical team, we'll help find them who they need to go see. We'll search that out for them in their area. We'll reach out to our networks. So it gives them, we always say it's kind of that missing tool. It gives them all those other pieces, and then we link them up so that they still get the specific one-on-one rehab that they do need. So.
Yeah, and when you're in clinic, you can focus on clinic things, essentially. So You mentioned there about people ramping back up going into the summer for social engagements, obviously Corona notwithstanding, but then also returning to sport is something. Now you've already mentioned that. What about returning to work? Because I don't know if people truly understand. Sometimes that can be quite a task in and of itself. Just getting back to the office and going to work for a 9 to 5 or whatever your job is. How do you go about broaching that and getting people back there and deciding when's the right appropriate time for them?
And that's funny. That's actually come up in Compass a lot. I think there's a lot of people who are trying to do that return to work, and it comes up in the clinic a lot too. And I think, you know, like anything, the big thing is understanding what are your job demands, what does your job require you to do, and it's important that before you even, in essence, consider going back to that you put yourself, so typically if someone's looking at return to work too, if they have the ability to work with an occupational therapist, that's wonderful, because occupational therapists are so great at helping facilitate return to work programs. But if not, basically what we say is if your job requires, 8 hours of, having conversations with people and processing data or whatever it is, you need to you need to put yourself in circumstances or situations that are similar to that and be successful at those before you start trying to do a return to work, right? So some will call it like work stimulating, some will call it like they'll volunteer at certain shops if they have like a type of job, but putting yourself in situations and circumstances that would provide similar stimulation as your actual job would before you consider that return to work. And if that's successful and you go into a return to work, then you don't go back to 9 to 5 right away. You see it, depending on your employer, of course, but is there a way to do a gradual re-entry to that workplace? And then are there certain accommodations that we can request so that you can be more successful, right? So if someone can go back to work, but overstimulation is huge and they work in cubicles, we need to figure that out. Either they need to be allowed to, is there a way to put them in a private office or a corner cubicle instead of the center cubicle? Can they wear a hat and headphones? Like, can we put accommodations in place to help them have success? We do want people to get back to work. We do want them to go back to these things, but just like return to sport or return to school is a gradual reintroduction, return to work is the exact same.
Now, coming back to your treatment, obviously, given the situation now, a lot of stuff has had to go online. How have you found treating patients with concussions online? Because a lot of your stuff, you have some kit that you utilize in order to be able to do it. So how have you found that?
Yeah, so it's actually been pretty good. So I've been doing, so we call it telehealth. I've been doing telehealth since 2017. And so I treat people all over BC, and then we're also allowed to treat in the Northwest Territories as well. For my concussion clients that, I already had in clinic stuff with them, they were super easy to transpire because I knew what I was working on already, and they actually loved it. And they've done exceptionally well because it's saving them the drive. They don't have to drive to and from the clinic. They don't have to leave. They don't have to be overstimulated. A lot more screen time for them because everything has transitioned into Zoom calls, right? But they're also a prime example where that app that I use to track progress has been wonderful, because literally I made the ones that weren't already using it, I just put regular clients on that the first day our clinic closed. And then I made them do a weekly check-in, because this was the one time in life that the only service I knew they were going to have was going to be telehealth. And so we could track to see, were we making change? And it was awesome because we were with every single one of them. And so being able to have that understanding, especially that group, we already had an understanding of their nuances. I already knew exactly what we were working on. So I could change stuff, tweak stuff, progress stuff. They were in their own home. So some of them were willing to work a little bit harder than they would have in the clinic because they knew they could just go lay down after. So they've done really well. I've also, however, gotten a lot of referrals from clients throughout British Columbia who are dealing with concussions, who live in areas who don't have people who who don't have therapists who treat concussion. And so then I'm doing an online assessment. And so it's a bit different in the sense that that app absolutely gets used so I can get balance and those scores for sure. I can get the cognition scores there. I also have a more in-depth cognitive screen that's done online that I can do as well, that looks at things like dual task and things like that. So we'll give them that. And then it's done through the screen. So I have basically, I have an ocular motor. I call it my ocular motor PowerPoint. So I have a video that I'll pull up, and they have a target to focus on, and I will have just them up on my screen, and I'll look at their ocular motor movement. I'll look at gaze stability. It's a little bit changed because I can't really do a head thrust, right? But if there's family members present too, I'll bring the family member in to help me do a little bit of the assessment piece. But particularly, I mean, when they have nothing where they are and then they're coming online with me, and again, we're making progress. But I will, especially if they don't have someone treating their neck, I will absolutely always try to link them back up with someone in their community to get some rehab on their neck. And so, for example, we had one person, she's doing really great. Her neck is definitely an issue. So we've looped her back to her physio to say, I need you to get some more manual. I need you to get some hands-on in-person care to work on the neck. After treatment with her on the neck, here's the exercises of mine I want you to do as soon as you get home.
Okay, what's that neck rehab?
So when I look at treating the neck, I'm looking at obviously muscle tone. I'm looking at, do we need manual therapy? Do we have smooth range of motion? Do we have strength and activation? But then that next level is, do we know where our head is in space? So do we have that cervical proprioception to know where midline is? Do we actually know where vertical is, or are we walking around like this? And then can we coordinate head and eyes together? I mean, we know if we do like VOR cancellation, you shouldn't see your eyes move because your eyes and your head should be going at the same speed. Right? So, can our eyes and head coordinate together? Can they move separately? And looking at all those different layers as well.
Now, for me, when it came to moving things online, it wasn't the best. For some of my colleagues, worked perfectly well going online, but for me, I just didn't really take to it. And I know that you also do online courses for people as well in order to help them take their clinics online and using telehealth. Can you maybe talk us through that a little bit as well while we're there, as we've just broached the subject?
Yeah, so I think when COVID hit, it was kind of one of those moments where we know a lot of people who are clinic owners, and we all had to close our doors. And so there was a lot of fear around, what am I going to do? So people were much more open to trying telehealth than they were in the past. And I realized that I had already done it, and I had already spent the hours making the mistakes and the hours making the phone calls to figure out what worked and what didn't, that there was no reason that other clinic owners needed to go through that as well. Like, I spent so many hours on the phone calling every single college across my country because there was no guidelines yet. There was no guidelines out about licensing. There was nothing. So I literally phoned every college in Canada to talk to them about telehealth.
Jeez.
Yeah, the answer I got a lot of the time was, Natasha, no one's asked us that before. We'll have to talk to our legal department and get back to you. That was the standard answer I got. So obviously there's some guidelines now, but there was no reason for clinic owners, in my opinion, to have to go through all that. So I created a course that was basically taking your telehealth practice from brick and mortar to virtual. And it was meant to give you everything you needed to literally set up your clinic online and do it over a weekend. And there's people that did that, and they started seeing 50, 60 telehealth appointments a week. So they just did awesome. The people that I find were the people that got challenged were the ones who try, and if this is you, I apologize, were the ones who tried to take exactly what they did in the clinic and do that online. Because you can't do that, right? If you are a manual therapist and that is what you love to do, and that is what you're good at, and that's what your clients have come to do, it's really hard to take that, because you can't, and shift it online, right? So you needed to change your framework and your mentality of how else you can serve your client besides just with your hands. And so my big thing is manual therapy, just that's a big thing in the physio world. So is needling, right? Dry needling, IMS. We know more than one way to release muscle tension. We just have our defaults, right? We know there's more than one way to retrain a muscle and to retrain strength. We just have our defaults. And so the people that really struggled were the people who had a hard time themselves shifting their mind away to, what else do I know in my skill set to be able to offer this client? But then, even if they got there, they had a hard time explaining that to their client and to get that buy-in, especially, and some clients just aren't appropriate, don't get me wrong. So that's kind of, those were the two people that kind of struggled, and it's that piece of, we have to remember why our clients come to see us. Our clients come to see us to help them not be pain anymore. Our clients come to see us to help, get stronger, get faster, whatever it is. They care about the outcome of why they're there. The process in between that can change as long as you're reaching the outcome. And I think the people that struggled to transition online, those were some of the reasons why they had a harder time doing that.
That makes a lot of sense. Reflecting onto myself, I mean, for me, it's not so much the manual side of it, but then it's still trying to take across what I do in the clinic, exercise-wise, with my patient, and how I'd assess what they were doing and try to refine the movements that I found really difficult to do online. And there's only so many times you can say to the patient, okay, now can you turn to the side for me? Okay, can you do this for me? Can you do that for me? Okay, great, yeah. And there's only so much that Brenda wants to listen to before she's like, all right, okay, here, let me smash the laptop shut. But no one did that. But, I can imagine it became frustrating as well for some of the patients, that they're constantly feeling like they're being puppeted about, which wouldn't be the feeling if we were there in clinic together. And it was my hang up more than anything else, I think. And that kind of made me pull back from really embracing that service. But yeah, nice. And you do that stuff online, right? Delivering the courses.
And I'm revamping it, actually. So right now it's a course you can purchase at any time, and do the course in it. The big one, I think, is like 4 hours, and then there's a clinician's course, which is just, you don't have to worry about how to bill and set up to get the stuff. And then there's the hybrid clinic piece, which is actually what I normally do, and which I encourage people to do now. So you have a hybrid telehealth in person. So your clients are blended in the sense that some sessions are in telehealth and some sessions are in person, and how that model can actually enhance client care as well. So there's a whole other course on that. So all of those are online. The format's changing in the sense that I'm going to refilm it so that it looks nicer. I'm going to update it because things are constantly changing. But then what isn't included in it now, you get to join a Facebook group, but there's no ongoing mentorship or coaching in that group, really. I'm going to add that piece to the course, because I do want, like, this conversation we're having, if you started telehealth, if we'd been able to kind of help coach you and mentor you through that hang up that you had, would you potentially have had more buy-in and been able to continue that revenue stream for your clinic? So I want to add that piece to the course as well, which isn't there right now. So that'll be coming in the next month or two.
Okay, fair. Pulling it back to concussions then, where do you think, from what you've read and what you do, the next steps are in terms of research and stuff for what people need to be looking into? Obviously, you said there was the Bennett and Marley's group, and then McKinley, was it?
For the
CTE
so
stuff?
McKee.
And then what about for concussions then? Where do you think the next?
So there's going to continue being, there's absolutely going to continue being a ton of research into CTE, and figuring out, trying to understand more of that. There's going to be and is more research happening around looking at the long-term effects of concussion and cumulative concussion, again, on future later life neurological issues, cognitive issues, emotional issues. That's going to continue to evolve as well. I would love to see I would love to see if there's more stuff that can come out about prevention. And I think as we start to understand some of the long-term effects potentially and have a greater understanding, even more so, of what's truly happening in our brains with concussions, then that's where maybe some of that preventative stuff will start to come out some more as well. But
okay. Have you got any particular reading recommendations for people listening to this?
Oh, I have like a slew of stuff. I'm trying to think. I don't have any so anything Letty is really fantastic.
Who, sorry? What?
So Letty from UPMC, John Letty. Anything he writes. So he writes a lot of stuff, especially if you treat acute concussion. He's done a lot of research on, that active aerobic exercise beginning like within I think his study is day 4, day 7 after concussion, and how that can improve recovery. Him and the group, they just released a study about cognitive intolerance, which is a new term that I quite like. In adolescents returning to school. So that's that basically cognitive activity brings on symptoms. So they just did a new study about cognitive intolerance. So he does a lot of stuff with acute concussion, which is really fascinating. The post-concussion, oh gosh, I'm honestly constantly reading. I don't have one author in particular that I read. I read basically anything and everything.
Fair enough. There's so much that goes into it, so yeah, I suppose there's too much for one person.
I mean, I read studies on ophthalmology, I read studies from athletic training, I read studies from looking at eye movement and behavior change, across the board. So
okay,
yeah.
How can people find you then if they want to get a little bit more information, or if they want to look up any of the courses or Concussion Compass or anything like that? How can people find you and get in touch with you?
So Instagram is probably the easiest, which is just at natasha.wilch, and then off my Instagram I have links to all my stuff. Also my website, which is just natashawilch.com.
Okay, yeah. Grand. Any other little bits or bobs that you want to,
Honestly, this is stuff that I could talk about forever. My biggest thing is that I truly want to see better awareness, and in people understanding concussion, as a profession, the amount of people that, if whiplash isn't resolving and there's still these concussion symptoms, because we know whiplash and concussion can mimic each other hugely. If the whiplash stuff seems to be improving, but these symptoms are still there, refer them out for additional help as well. Just identifying it sooner so that we can help people sooner, improving our acute recovery and improving our acute management so that less people hopefully develop the post-concussion syndrome. So my big thing is just improving awareness and education, because if we can do both those things, we should see better outcomes for concussion across the board.
Awesome. Well, look, really appreciate your time, being able to have a chat with us, and thank you so much. Yeah. Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time, and if you have any comments or suggestions, feel free to get in contact and let us know. Until next time. Peace.